When we're looking at the clinical trials using vitamin D3, we have to have certain criteria for evaluating those studies, and I published this list in 2005 in the British Medical Journal. We want to look for competent dosing. Now, if that's for preventive or maintenance use, that would be approximately 3,000 to 10,000 international units per day for adults. Dosing for acute situations such as an active infection would be slightly different. We might use vitamin D3 at 60,000 to 80,000 international units per day for 14 days, or we might use the form of 25-hydroxyvitamin D at an average of 90 micrograms per day for 15 days, starting on the first day with a loading dose, and we'll take a look at several studies that have used that type of protocol. So let's assume that we have competent physiologic dosing in these studies for adults with approximately 10,000 international units per day, or for more acute response, 60,000 to 80,000 international units per day. We want to make sure that the timing is right. Usually that comes down to a competent duration of at least 5 to 9 months for repletion. Obviously, in the acute studies, we have to look at shorter duration, but either way you look at it, we have to look at the timing of intervention with respect to the timing of the disease. We want to make sure that studies have used the proper form of vitamin D, and that's typically vitamin D3 for preventive or long-term use. And again, in more acute situations, we can use 25-hydroxyvitamin D. But in either case, we would never use vitamin D2, also called ergocalciferol. Point number 5 here is that we need to make sure that the products are effective, so we either have to assay the supplement and or measure blood levels of 25-hydroxyvitamin D after supplementation so that we know for sure the product was produced properly and also absorbed and metabolized properly. Typically what we're looking for is point number 6 here, a therapeutic differential. We want to see people who are deficient move to a state of irrefutable sufficiency. So if they started out deficient at the beginning of the study and at the end of the study they're still deficient, then obviously that wasn't a therapeutic differential. So we wouldn't expect a very robust clinical response. Again, typically we need to mobilize patients from a state of deficiency to irrefutable sufficiency, which is at least 40 to 50 nanograms per milliliter, also written as 100 to 125 nanomoles per liter. And finally, again, point number 8, pharmacologic competence, no bolus dosing of vitamin D3. So I consider bolus dosing certainly to be 100,000 units or above. I think that we could consider this to be high-end physiologic dosing, 60 to 80,000 international units per day. This is within physiologic endogenous production, for example, after a day of sunbathing or using a tanning salon. But you'll see that we start to encounter problems on a consistent basis with doses of 100,000 international units per day or more. So again, no bolus dosing of vitamin D3. Dosing must be daily or weekly. And I've produced some blogs, articles, and videos relative to this topic, one of which you can see here, which is available for free access at the academia website. So here I'll show you very quickly the normal pharmacology of vitamin D supplementation. So typically when people are deficient and they begin taking a vitamin D supplement, we need at least 4, maybe 5 or 6 weeks before they begin to plateau if they're taking approximately 5,000 international units per day. If we double that, which would certainly be reasonable, at 10,000 international units per day, you can see that the curve plateaus at about week 9 or week 10, but they are clearly still at the steep slope of the curve at weeks number 1, 2, and then starting to flatten out by week number 3, but they don't reach the optimal peak, again, until week number 9 or week number 10. Typically, our clinical goal is to get people to at least 80 nanomoles per liter, also known as 32 nanograms per milliliter. So again, if we're starting out at deficiency, we typically need at least 2 or 3 weeks to get people into that range. And again, this chart represents the serum response of 25-hydroxyvitamin D to supplementation with physiologic doses of vitamin D3. Starting at deficiency, blood levels become adequate at about 2 or 3 weeks, whether we're using 5,000 international units per day or 10,000 international units per day. If we look at the effect of bolus dosing, we see a completely different picture. When patients are exposed to a bolus dose of 100,000 international units, we see that their vitamin D level peaks very high for about 10 days and then comes crashing down. This is the serum level of vitamin D3, not 25-hydroxyvitamin D. Again, when patients take a bolus dose of 100,000 international units, they get a dramatic spike that lasts for about 8 to 10 days of vitamin D3 in the blood, which provokes a somewhat antagonistic response at the vitamin D receptor. As you would expect, after this vitamin D3 leaves the blood, it goes into the tissues and maintains very high levels of vitamin D3 in the tissues for approximately 3 months. During this 3-month period of time, vitamin D3 continues to have an antagonistic effect against the biologically more potent 25-hydroxyvitamin D. Following bolus dosing, 25-hydroxyvitamin D levels start to increase, but don't really peak until about, again, week number 1 up to week number 4. So let's take a moment to remember the implications of this graph. Following bolus dosing, D3 levels are very high in the blood. That D3 moves into the tissues where it stays high in the tissues for approximately 3 months. The biologically active form, 25-hydroxyvitamin D, needs at least 1 to 3 weeks to peak following the administration of bolus dosing. So again, bolus dosing of vitamin D3 does not become active 25-hydroxyvitamin D immediately. This takes at least 1 to 3 weeks. And during that 1 to 3 weeks following bolus dosing, vitamin D3 levels are high in the blood and the tissues, and this has an antagonistic effect against 25-hydroxyvitamin D at the vitamin D receptor. Now, if you understand the details and the concept of this graph, then you can understand why research such as this from the New England Journal of Medicine is basically research that was designed to fail. They call this early high-dose vitamin D for critically ill vitamin D deficient patients. They gave these patients an amazing 540,000 international units of vitamin D3. Well, if this is the graph representing 100,000 international units of vitamin D3, what do you think the graph would look like for 540,000 international units of vitamin D3? Obviously, it would be off the page here. And of course, the results were neutral or negative, and they concluded that vitamin D had no role in the treatment of these vitamin D deficient patients, which is completely absurd. The reason that vitamin D3 did not function with therapeutic efficacy in these patients is because the vitamin D level spiked, then remained high in the tissue while it created an antagonistic effect against 25-hydroxyvitamin D. Meanwhile, 25-hydroxyvitamin D levels were slow to increase, but they did increase, however, within a context of biochemical and physiologic antagonism. So this explains why you see the repeated failure of bolus dosing. It looks heroic, it looks effective, and for people who don't understand this pharmacology of vitamin D, they would think that this is adequate treatment, but it's not. It's the reverse of adequate treatment because a lower dose would actually be more effective. When the body is exposed to this massive supraphysiologic dose of vitamin D3, that causes the induction of the enzyme and clearance systems that help to clear out excess vitamin D3. So that also helps explain why we see a rapid rise of 25-hydroxyvitamin D3 levels and then a rapid decline of those levels following bolus dosing. If the same amount had been administered in a more physiologic manner, we would see a rise and then a maintenance of that elevated level of 25-hydroxyvitamin D. But when patients are exposed to a high supraphysiologic bolus dose of vitamin D3, that activates the enzymes that clear out excess vitamin D, and that's why we see a peak and a decline. And this is the accurate explanation for why vitamin D needs to be administered on a daily or weekly basis and why we have to avoid bolus dosing. And that's because it's been shown to provide predictably negative or neutral results, and we're not in business for negative or neutral results. We want benefit, which means we have to avoid bolus dosing. I also published some different criteria in 2017. You can pause the video to take a look at that. And related to the improper use of vitamin D, I've also provided this list of different types of fraud, whether it's obvious or hidden, and also the type of intention and activity. As I've said before, we want vitamin D levels to at least reach 40 nanograms per milliliter or 100 nanomoles per liter. This is what I published in 2004. More recently, I think we should aim for an optimal physiologic range of 50 to 90 nanograms per milliliter, also known as 125 to 225 nanomoles per liter. That is the normal physiologic range for sun-exposed humans. And to get people into that range, we should have started population-wide vitamin D supplementation at least 17 years ago after I published this article in 2004. By failing to provide population-wide vitamin D supplementation, we have invited pandemics of early death and infectious disease. As I said in 2004, failure to act prudently based on the research now available in favor of vitamin D supplementation appears likely to invite repetition analogous to the previous failure to act on the research supporting the use of folic acid to prevent cardiovascular disease and neural tube defects, a blunder that appears to have resulted in hundreds of thousands of unnecessary cardiovascular deaths and which has contributed to incalculable human suffering. And what I said here of folic acid clearly applies now to vitamin D and our failure to implement population-wide supplementation. So now let's start looking at the evidence. I'm going to focus on HPV, dengue, hepatitis C, and HIV, respiratory infections, and the so-called novel coronavirus or COVID-19 virus. So topic number 1, human papillomavirus. These are the viruses or the virus family that causes skin warts and also famous for being associated with cervical cancer and probably receiving too much blame for cervical cancer.